exactly how cardiologists make those critical life or death intervention decisions in modern practice. Honestly, it's an incredible blend of structural engineering, plumbing, and electrical work. So if you've ever wondered how the heart team actually decides who gets a stent, who gets open heart surgery, and who just gets medication, you are definitely in the right place. Let's dive in. Here is our roadmap for today. We'll start with the foundation, indications and risk. Then we'll look at the plumbing with coronary interventions, check out the doors and walls via valvular repairs, examine the electrical grid, and finish up with the complex pressure systems of hemodynamics. All right, section 1, the blueprint. Let's look at evaluating indications and risk. So just because we spot a narrowing on a scan, do we instantly rush in to fix it? You might think so, but the answer is a hard no. Just because we see a narrowing on an angiogram doesn't mean we automatically grab a balloon or a stent. In fact, if we don't meet some very strict clinical goals, we actually rely on optimal medical therapy instead. We literally only intervene if the procedure guarantees one of 4 specific life-saving outcomes. Will it genuinely relieve the patient's unbearable symptoms? Will it statistically improve their overall survival? Will it prevent sudden cardiac death? Or are we treating acute clinical instability right this very second? If a procedure doesn't hit at least one of those exact marks, well, the catheter stays on the table. But it's a huge balancing act, right? The heart team has to meticulously weigh those goals against some pretty severe potential risks. We're constantly asking ourselves, is this intervention going to cause a severe bleed or a stroke? Will the contrast dye injure their kidneys? Is the patient simply too frail? Or are there hard contraindications like an active infection or a severe non-cardiac malignancy that's going to limit their lifespan anyway? In those scenarios, an invasive procedure could actually do way more harm than good. Moving right along to section 2, the plumbing. Let's talk coronary interventions and diagnostics. When we're treating the complex plumbing network of the coronary arteries, we usually start by getting access, preferably through the radial artery in the wrist rather than the groin. But the real magic happens inside the vessel itself. Before we fix a blockage, we have to know exactly how bad it truly is. We use incredible internal diagnostic tools for this. FFR and IFR are these special pressure wires that check the actual physiological pressure across a narrowing. They tell us if an intermediate blockage is actually restricting blood flow. We also use advanced imaging, like IVUS and OCT, to get high-resolution virtual histology right inside the artery. This dictates exactly how and when we deploy a stent, especially in tricky spots like the left main stem. Okay, keep this one critical number in mind, 120. In cardiology, we always say time is muscle. During a severe emergency like a STEMI heart attack, where an artery is just completely blocked, our entire strategy revolves strictly around a 120-minute timeline. The absolute goal is to get that patient to a cath lab and get that artery open in under 2 hours. But what happens if that patient rolls into a hospital that just isn't equipped with a cath lab, and a transfer would bust that 120-minute window? Well, we trigger a highly choreographed 3-step race against the clock. Step 1, we immediately hit them with heavy clot-busting drugs called fibrinolytics. Step 2, we rapidly transfer the patient. Step 3, we perform the angiography. Literally every minute saved is heart muscle preserved. Now, for chronic conditions, it's a completely different story. The patient's anatomy and overall health drive our triage matrix, where we compare CABG against PCI. CABG, open heart bypass surgery, remains the life-saving gold standard for complex multi-vessel disease, especially in diabetics, because it's proven to reduce mortality. But PCI, or stenting, is the go-to alternative when a patient's surgical or frailty risk is just too high, or if their anatomy is simpler. We're just matching the right tool to the patient's unique risk profile. And here is another magic number for you, 12. There is a massive catch with elective stenting, and it comes down to the rule of 12. A patient's inability to strictly adhere to 12 full months of dual antiplatelet therapy, meaning heavy blood thinners, is a hard clinical stop. If they can't take those meds for a year because of bleeding risks or compliance issues, a stent could clot and cause a massive fatal heart attack. That changes the entire intervention strategy right on the spot. All right, section 3. Let's look at the doors and walls of the heart, valvular and structural repairs. Let's say a patient presents with severe aortic stenosis, a tightly narrowed heart valve. This comparison perfectly highlights the modern approach. Younger, lower-risk patients under 65 who have decades of life ahead of them, they're directed toward traditional open surgery, or SAVR, for a highly durable fix. Conversely, for frail patients over 80 who have prohibitive surgical risks, we use TAVR. It's a minimally invasive method where we literally deploy a brand new valve right through a catheter without ever opening their chest. It's wild stuff. Now, for a severely leaky mitral valve, we have TEER, transcatheter edge-to-edge repair. It's this brilliant tech that essentially clips the leaky valve leaflets together. But the guidelines here are strict. We only use this if the patient is still symptomatic despite being totally maxed out on optimal medication. And crucially, their ejection fraction has to sit precisely between 20 and 50% for the intervention to actually work. We also have incredible structural fixes like LAA occlusion. Atrial fibrillation causes blood to pool and clot in a small pocket of the heart called the left atrial appendage, which can lead to devastating strokes. Normally, we prescribe blood thinners for this, but if a patient has severe bleeding issues and absolute contraindications to long-term anticoagulation, we go in with this umbrella-like device. It physically plugs the appendage entirely, stopping the clot from ever escaping. Moving to section 4, the electrical grid. This is where electrophysiology and pacing come in. When we are facing an electrical rhythm emergency, the very first question the heart team absolutely must ask is the patient clinically unstable? The answer to that single question completely dictates whether we have the luxury of time to try medications or if we need to deliver electricity right this second. To figure that out fast, we use a diagnostic framework known as the shock pentagon. If a patient with a massive arrhythmia hits any of these 5 marks, low blood pressure, signs of heart failure, ongoing ischemic chest pain, a dropping level of consciousness, or full-blown shock, they are deemed unstable. In those scenarios, immediate synchronized cardioversion or emergency defibrillation is mandatory, no questions asked. But if the patient is stable, we have a bit more time. The approach becomes incredibly targeted. We use precise anatomical maps to burn or freeze specific problem areas causing the misfires. For AFib, we isolate the pulmonary veins. For atrial flutter, we target the cavo-tricuspid isthmus. And for WPW syndrome, where an extra electrical pathway causes rapid heartbeats, we go in and ablate that specific accessory pathway. We also have to manage the ever-present risk of sudden cardiac death when pumping capacity drops. Take a look at these ejection fraction thresholds. For slow rhythms, symptom correlation is key for basic pacemakers. But when a patient's ejection fraction drops to 35% or below, an ICD, an implantable cardioverter, becomes a necessary tool to shock the heart back to life if a lethal rhythm happens. And if we add a wide left bundle branch block to that low ejection fraction, meaning the heart walls are beating out of sync, we upgrade to CRT, cardiac resynchronization therapy, physically paces both sides of the heart to force them to squeeze together effectively again. Finally, Section 5, Pressure Systems. Let's talk hemodynamics and ICU triage. When you're in the ICU and the clinical picture is just murky, things aren't making sense, we turn to a right heart cath. We thread a catheter through the veins and directly into the right side of the heart. Instead of looking at blockages, this tool measures the actual real-time internal physiological pressures of the heart and lungs. Getting these hard pressure metrics allows the team to instantly differentiate between confusing shock states. Is it cardiogenic, distributive, obstructive? We can figure it out. It's also absolutely crucial in advanced heart failure to evaluate pulmonary vascular resistance reversibility. Honestly, this data is the ultimate deciding factor before we commit a patient to incredibly heavy interventions, like mechanical support pumps, or before clearing them for a full heart transplant. So, as we wrap up this explainer on the modern heart team playbook, I want to leave you with something to chew on. Given the explosive innovation in transcatheter fixes, we are actively replacing valves and fixing major structural defects through tiny holes in the wrist or groin. How soon will today's complex chest-cracking open heart surgical matrices become entirely obsolete? The basic architecture of the heart hasn't changed, but our tools for repairing it are evolving faster than ever before. Keep paying attention to this space, and thank you so much for learning with me today.